Hello and welcome. My name's David and I'm an anaesthetics trainee from Sydney, and today I'm going to be taking you through an introduction to double lumen tubes. By the end of this presentation, you should be able to identify patients which should or should not have a double lumen tube inserted, identify the correct double lumen tube for your patient, and know how to confirm your double lumen tube is in the right position. So I guess the first question is, what is a double lumen tube and what is different about a double lumen tube compared to the standard single lumen tube that most of you would be familiar with? Here we can see a standard single lumen tube. We can see that it has one inflatable cuff which is attached via the pilot used to deflate and inflate it. It has a single bend in the tube as well as a Murphy's eye on the end. It connects to our ventilator via a standard 15mm connector on the end. Here we have a picture of a double lumen tube. The first things you will notice is that there are two cuffs and two pilots. There are also two distinct lumens, and each of these is labelled a bronchial or tracheal. Traditionally, the bronchial cuff, as well as the lumen, will be blue and the tracheal will be white, as is the case with this tube. You will also notice that it has two distinct curves, one in between the tracheal and bronchial cuff called the bronchial curve, and a second curve known as the pharyngeal curve, which extends proximal to the tracheal cuff. These are important, and we'll talk more about these later. So the first and most important thing to recognize is when a double lumen tube is essential or necessary. And these, generally speaking, are situations where you want to isolate one lung from the other. And this might be to avoid contamination in cases where you have active pulmonary hemorrhage, infection or abscess, to control where your ventilation is directed in the case of a bronchopleural fistula, or where you might want to consider doing unilateral bronchopulmonary lavage. A relative indication is to improve surgical conditions. Although this is a relative indication, this would be the most common reason for us inserting a double lumen tube, to improve the view of vital structures during cases such as thoracotomies. It is always important to discuss the decision to insert a double lumen tube with the surgeon operating. Let's talk a bit about contraindications for double lumen tubes. The first and most common is a small patient. This generally precludes the use of double lumen tubes in the pediatric population and also small adults. Double lumen tubes, by their very nature, are much larger than single lumen tubes, and we'll talk a bit more about the size later. The second contraindication is an anticipated or known difficult intubation where the patient has distorted or abnormal anatomy, making a placement of a double lumen tube impossible. The third is a relative contraindication, and that is where a rapid sequence induction is indicated. Thankfully, there are alternatives. The most commonly used is something called a bronchial blocker, and this is the most common way for achieving lung isolation in the pediatric population. The second option is endobronchial intubation with a single lumen tube, and this is not ideal and not recommended, but may be used in an emergency situation. So let's recap. Why do we use double lumen tubes? We use them because they allow us to physically separate the right lung from the left lung, and this allows us to direct or stop the flow of pus, blood, lavage fluid, or even air. It's important to realise that double lumen tubes are not the only method for achieving lung isolation. So let's check your understanding of what we've gone through so far. A 32-year-old man presents with a stab wound to his left chest. He has a left-sided chest drain inserted and then proceeds to have a CT scan. The CT scan shows a laceration of a lobar bronchus. He now needs to have a general anaesthetic for drainage of a hematoma and hemothorax. Does this patient require a double lumen tube? If you're unsure about the answer to this question, rewind and review what we have gone through. Now that we've covered which patients should or should not get double lumen tubes, it's time to decide which double lumen tube to use for your patient. There are three important considerations: the style of tube, the size of tube, and which sided tube. In reality, two of these decisions will almost always be made for you. The style of tube is generally dictated by the hospital which you are in. Most hospitals will only stock one particular style. Determining the size of the double lumen tube is controversial, and there are a variety of methods used to predict which tube will fit appropriately. Unlike a single lumen tube, in which we want the tube to fit in the trachea with an audible leak prior to inflation of the cuff, when fitting a double lumen tube, we are looking for these same requirements in the bronchus in which we are intubating. It is important to know that the size of the tube is not delineated by the internal diameter in millimeters, such as with single lumen tubes, but rather in French gauge, based on the external diameter, with the common sizes being 35 to 41. The three most common ways of deciding which size double lumen tube will fit your patient is a simple rule of thumb, where women get a 35 or 37 French gauge double lumen tube, or men get a 39 or 41 French. The second is to use imaging, such as a chest X-ray or CT scan, to measure the diameter of the bronchus in which you want to intubate. Again, it's important to note that the French gauge or sizing of these tubes does not tell you the diameter of the bronchial lumen, although these are always marked on the tube itself. The third method is to use the patient's finger size as an approximation of their bronchial size. As you might have guessed, double lumen tubes can come in left-sided or right-sided tubes. To understand why we choose one tube over the other, we need to have a closer look at the airway anatomy. The most significant feature you can see here when considering intubation of a bronchus is that the left main bronchus is considerably longer than the right main bronchus. This means that there is a higher margin of safety in terms of where we place the end of the double lumen tube. For this reason, left-sided double lumen tubes, which intubate the left main bronchus, are always preferred where possible. There are, however, situations where it is not possible to place a left-sided tube, and these include operations involving the left main bronchus itself, or if there's an obstruction which would prevent you from passing the left-sided tube. So let's recap. We mentioned before there are three main factors to consider when deciding which double lumen tube to use for your patient. The style, we said, will most likely be determined for you. The side is almost always left. And a simple rule of thumb is a 35 or 37 French for women and 39 or 41 French for men. So let's check your understanding. A 30-year-old man who's 185 centimeters tall presents for a left VATS pleurodesis. He has a pneumothorax but no chest drain. Which tube will you choose? Does this patient need a double lumen tube? If so, what size and what side? If you're unsure, review the last section. So now that we've talked about which patients require a double lumen tube, which double lumen tube you will choose, let's now talk about how we put the double lumen tube in. The two most common ways to put a double lumen tube in are via direct or video laryngoscopy, or after intubating with a single lumen tube, passing an airway exchange catheter, removing the single lumen tube, and then passing the double lumen tube over the catheter. Bronchoscopic intubation is possible, but generally not used. The bronchoscope is generally relied upon for confirmation rather than placement of the tube. Again, here we have a double lumen tube. And as we pointed out earlier, we have a bronchial bend and a pharyngeal bend. These are important when intubating. The bronchial bend and bronchial tip should be facing anteriorly as the tube passes through the glottis. As the tracheal cuff passes through the glottis, we need to rotate the double lumen tube 90 degrees towards the bronchus which we want to intubate. This then allows the bronchial curve to aid placement successfully, while the pharyngeal curve ensures that the tube sits snugly. This is a diagram illustrating what we have just talked about. In this case, this demonstrates a left-sided double lumen tube, which you can see is rotated 90 degrees as the tube passes through the glottis. Both cuffs are then inflated, the bronchial and tracheal cuff, before appropriate placement is tested. This is the apparatus which attaches to both lumens of the tube. Generally they will also be colour-coded, blue for bronchial and white for tracheal. There are three important features to highlight here. There is a port for the bronchoscope to fit through. These ports can also be left open when we want to intentionally collapse the lung. The soft tube segment is where we clamp or isolate a lung, preventing airflow from the ventilator to a particular lung. This segment is designed to avoid long-term damage on clamping and unclamping, where leaks or persistent resistance related to deformity may occur. At the end, we have a standard 15mm ventilator connector. So let's recap. Most double lumen tubes come with a stylet, which should be used to aid insertion. A video laryngoscope may be used, and this may assist you in improving your view of the tube going through the glottis, as on direct laryngoscopy, the tube, because of its large size, may completely obscure your view. Again, significantly, make sure the bronchial bend is forward or anterior, advance through the glottis, then rotate 90 degrees and advance down towards the bronchus you wish to intubate. Let's check your understanding. When inserting a right-sided double lumen tube, will you rotate the tube clockwise or counterclockwise upon passing through the glottis? Now that the tube is in the airway, how do we confirm that it's in the right spot? A helpful acronym to use is IPAD, which stands for Inspection, Palpation, Auscultation, and Direct Visualization. Initially, we want to ensure that the double lumen tube is in the trachea. If it is, when we ventilate, we would expect to see chest rise and fall, as well as fogging inside the tube. As we bag the patient connected to the circuit, we should get the characteristic recoil, which suggests that the tube is within the lung. Thirdly, we auscultate both lungs via the axilla, the left and right, to ensure that both lungs are being ventilated. This, of course, does not apply in situations where you must isolate the lung immediately. Observation refers to seeing end-tidal CO2 on the anesthetic machine. The fourth and most important method is direct visualization. This is normally done using a bronchoscope, and we will now talk about this in more detail. It is very important when confirming the placement of a double lumen tube that you understand and quickly recognize what the lung looks like when viewed through a bronchoscope. The picture on the left shows us the major airways of the lung. The red dot signifies the tip of the bronchoscope. Currently, the bronchoscope is sitting in the trachea. We can see the double lumen tube to our left. We can see a crescent-shaped blue ring. This is the cuff of the bronchial lumen. But how do we know whether it is in the left or the right main bronchus? We need to orientate ourselves. We can see that the carina is there, or what we think is the carina. We definitely know it is a bifurcation. A useful orientating landmark is the trachealis muscle, which you can see there is always posterior in the lung. By using the trachealis muscle, we can see that the tube is definitely going down the left side. We then advance the bronchoscope. Keep in mind this is going down the tracheal lumen of a left-sided double lumen tube. As we advance down into the right main bronchus, we can then turn our bronchoscope up and we will see the orifice of the right upper lobe with its characteristic trifurcation. This allows us to confirm that indeed we have entered the right side of the lung, and this allows us to reconfirm that indeed the double lumen tube was entering the left main bronchus. Advancing past the right upper lobe, we come to the bronchus intermedius, which leads on to the right lower lobe and right middle lobe. Now that we've already confirmed that our left-sided double lumen tube is in the correct bronchus, we need to make sure it is positioned appropriately. For this, we must now go down the bronchial lumen, and upon exiting the bronchial lumen, we find ourselves in the left main bronchus. Here we can see the characteristic bifurcation leading to the left upper and left lower lobe. So now that you've had a quick run through of the bronchial anatomy, let's go through it in real time. Try to figure out the salient features and see if you believe this tube is in the right spot. Were you able to identify the landmarks? If not, rewind and review. If you need to, watch the video of the bronchoscope a few times and try to identify the characteristic features. In particular, try to familiarize yourself with the order in which landmarks appear. So let's recap. We confirm our tube is in the right spot using iPad. The most important component of that is direct visualization. We always go down the tracheal lumen first. We visualize the trachealis muscle to orientate ourselves, and then we confirm that the correct bronchus is intubated. We then go down the bronchial lumen to confirm that our bronchial tip is correctly positioned. In the case of a left-sided tube, going down the bronchial lumen will reveal the left main bronchus, followed by the left upper and lower lobe, lobar bronchi. In a right-sided tube, it is slightly different. We will have a separate opening within the tube for the right upper lobe. Therefore, we look for this opening and aim to line the tube up so that we see the characteristic trifurcation that we saw earlier. Importantly, we must then secure the deck double lumen tube. We must reconfirm the positioning of the tube with each position change. Let's check your understanding. You decided to intubate a patient with a left-sided double lumen tube. You attempt to deflate the right lung. Which lumen will you clamp? The tracheal or the bronchial? Now let's say you've decided to clamp the correct lumen. You continue to hear breath sounds in both lungs. What could be the problem? How would you solve it? These are two very useful references if you'd like to learn more. Thank you for listening, and I hope you enjoy your time with thoracic anaesthetics.